Welcome to NoseTalk, or for some of our listeners here today, welcome back to NoseTalk. NoseTalk is an educational podcast series in association with the European Rhinologic Society Juniors, where we talk about some of the most important and interesting topics in rhinology. I'm your host, Dr Rory O'Neill, and this is episode 2 of the series. In the last episode, we talked about juvenile nasopharyngeal angiofibromas with Mr. Shaukat Abdulrahman. In today's episode, we're going to be talking about sinonasal malignancies with more of a focus on the most common subtype, squamous cell carcinoma. This is obviously a huge topic that even a full podcast series on the topic wouldn't cover. So today on this episode, we're going to aim to give our listeners an overview of this and cover some of the main points on this fascinating topic. Joining me on today's podcast is Dr Apostolos Karligkiotis. Dr Karligkiotis is an otolaryngologist, head and neck surgeon working at the Department of Otolaryngology at University Hospital of Varese in Italy. Alkis is an anterior skull-based surgeon and rhinologist. His main research interest is expanding the limits in the field of endoscopic sinonasal, orbital and skull-based surgeries. He's actively involved in academic research and currently sits on the editorial board for Acta Otorhinolaryngologia Italica. Alkis, it's my great pleasure to welcome you to the podcast today.
Hello, Rory. Hello, everyone. It's a pleasure for me to take part in this podcast. Thank you very much, the European Rhinologic Society, for the invitation.
Brilliant. Thanks, Alkis. So I'm going to get us started. For our listeners today, sinonasal malignancies are one of the less common sites for head and neck malignancies and account for approximately 0.5% of all head and neck malignancies. They're an incredibly diverse range of malignancies from a histopathological perspective. The WHO, for example, has an extensive list of sinonasal malignancies based on histopathological subtype. My first question for you today, Alkis, what are your views on the histopathological diversity of this fascinating disease?
This is a very rare pathology, and it's amazing how in such a small district of the human body, so many different tumors can grow from different tissues, because we have glands, we have vessels, we have nerves, and it's maybe the area with the most popular, the vast majority of different tumors that can grow inside. We have, if we consider the head and neck district, this is only around 3% of all tumors that can grow. Of course, different districts in the head and neck are more frequent than the sinonasal tumors.
Absolutely, a very diverse range of malignancies and quite a small anatomical area, really. So we know that these are rare tumours, but Alkis, what is your experience of risk factors for these malignancies? Are there certain patient groups that, for example, you see these tumours occurring more frequently? Or are there risk factors that you think are very potent for this condition?
So to be honest, there are some tumors that have a specific occupational etiology, and in particular, the intestinal type adenocarcinoma is a well-known cancer that grows in woodworkers and in leather workers. So these are the main categories that have these cancers. And even if the exposure is for a short period of time, the possibility to develop such a cancer is very, very high.
Absolutely. It's very unusual for head and neck cancers in general. It seems to be the only type of head and neck cancer, certainly that I'm aware of, where woodworking and other types of adhesives can be such a potent risk factor.
Exactly. So different studies have showed that these categories of patients develop the intestinal type adenocarcinoma in particularly. On the other hand, there are other studies that shows, for instance, for squamous cell carcinomas, that workers in the nickel with nickel compounds can develop by inhalation, can develop squamous cell carcinoma in the nasal cavities. So these are the main risk factors for a professional exposure. In the past, different substances that nowadays are not used, like the radium paintings or Some radio contrast, like the thorotrust, have been correlated with the development of carcinomas of the nasal cavities. But nowadays, these substances are not available anymore, so we don't have any exposure of the people or cancers developing from such exposure.
Certainly, improvements in exposure to occupational risk factors certainly represents a positive trend. What is unusual for these type of malignancies is that, compared to a lot of other type of malignancies in the head and neck, smoking seems to be much more weakly associated with this. There don't seem to be strong associations between smoking and many types of sinonasal malignancies.
Exactly. Smoke is not so much correlated. There is some correlation. However, if you think that for laryngeal cancer, the smoke and alcohol are the most frequent etiology factors for sinonasal cancer, it seems that increase the risk smoking only 2 to 3 times than normal population that doesn't smoke. There are some studies in some specific areas that they use the snuff. Snuff is tobacco that is getting sniffed, and it shows that, for instance, in South Africa, the population that use this kind of tobacco has bigger incidence of sinonasal cancer.
Wow, that's very interesting anyway to see data from that. There's certainly been some research recently looking into possible associations between a human papillomavirus and the pathogenesis of sinonasal SCC. Is that something you've seen in your practice very frequently at all?
There are different studies reporting that HPV can be one of the risk factors for development of SCC. We know SCC can origin as de novo SCC in the vast majority of squamous cell carcinomas, in the vast majority of the cases, and can develop on originating from inverted papilloma. So inverted papilloma is a benign tumor, the most frequent epithelial sinonasal benign tumor. And sometimes, in approximately, I would say, 10% of cases can develop in squamous cell carcinoma. And in that case, it could be synchronous, that meaning that presentation is at the same time, or it can develop metachronous, meaning that after some period of time that has been treated, some months, can be 10 months, can be 100 months, there might be a recurrence of the disease, and on that recurrence, we might find a metachronous SCC, so an association with squamous cell carcinoma. So the role of HPV is not clearly understood yet. There are different studies that have been done by using PCR analysis, and I would say that approximately 25% of the cases of squamous cell carcinoma are related to mostly to inverted papilloma can present an association with the HPV infection. In our experience, we had a study and we only found that there was an association in 10% of cases of inverted papillomas that transformed in squamous cell carcinoma. And in these cases, in our research, was about 80 cases. We only identified the 10% almost of association, and there were only low-risk HPV genotypes and not the high-grade like 16, 18 HPV.
Fascinating to hear about your research on this specific topic. So I think we should move on to presentation. In your experience, patients getting referred to yourself present with sinonasal malignancy. What symptoms do they typically present with?
So the problem of an area, which is an air cavity, the symptoms are very aspecific. Usually they present as unilateral symptoms, commonly nasal obstruction, rhinorrhea with some mucus coming out, and these patients and their GP usually think that there might be some kind of sinusitis, and they give him some treatment for the nose, and this not passes, then they have persistent disease, and so they will get to the specialist once they have persistent symptoms or more important symptoms that are getting worse than the months before. And this is the problem, because usually these kind of patients present with advanced stage disease, because it's more possible for the tumor to grow to the upper part rather than to the lower part, so have bigger maybe symptomatology earlier. And one other symptom is the epistaxis, but this is a symptom that usually comes when the tumor is already big enough, in my experience.
Okay, very interesting. So I suppose there's a lot of overlap between the symptoms that a patient with a sinonasal malignancy could present with and a patient with benign sinus disease. But I suppose really worrying signs for our listeners out there, unilateral symptoms and certainly any sign of epistaxis really are two things that really should be getting our alarm bells going. So do you see patients, for example, presenting with signs of advanced disease very frequently in your practice, or is this a smaller part of the patients you see?
So usually I can tell that there are rare cases that present with advanced disease, like involvement of the orbit with proptosis or diplopia, visual loss. Sometimes patients may present with some neurological deficits or changing of their personality due to neurological invasion of the tumor. But this is usually a minority. So normally we don't have this presentation of the patients. However, it happens to see such a patients in our department, which is a referral department for such kind of surgery and treatment of tumors. So we have a lot of patients.
Fascinating. I can certainly appreciate that although advanced presentations may be less common in many units, your unit in particular in Varese, I understand, probably sees these patients present more frequently. As I understand, you get referrals from many different countries internationally. So, Alkas, you've seen a patient in clinic referred with unilateral epistaxis and diplopia. You examine them and you see a highly suspicious mass in the nasal cavity. How do you proceed? For example, what investigations would you typically perform?
So exactly, of course, after endoscopy and having an evaluation of the mass inside the nose, it's fundamental to have radiology to define what are the characteristics of this mass. So for first radiology examination, I will ask for a CT scan and a MRI of the nose and paranasal sinuses and brain included.
What sort of things are you looking for in imaging? Are there any specific features, or what are the most important things you're looking for on the imaging?
Yeah, of course. So these two exams are complementary. One is complementary to the other. So it's not possible to have only one or the other. Of course, if it's not possible to have MRI for, I don't know, the patient has some metal implants that don't permit to have the MRI, we will have only the CT scan, but these are only rare cases. Or maybe the patient has some claustrophobia or something like this. So these are two exams that are complementary and are very important because give different information one to the other. So, of course, you need to evaluate the bone erosion, if there is any reabsorption of the bone, what are the extension of the disease of the mass that you have seen, if it's going towards to the orbit, if it's going to the brain, there is any extension to the cavernous sinus, to the carotid artery, to the optic nerve. What would be then the dimensions, of course. Other things that you need to see is the contrast enhancement on MRI. So CT scan is not necessary to have a contrast enhancement, but MRI, of course, you need to have contrast enhancement and all the other sequences, like the FATSAT and FLAIR, that will give more information. Then based on these features, and when you have seen also the enhancement of the MRI, you can have better idea of what are you having to deal with. Of course, these are not exams that giving you the possibility to have diagnosis. So you can have a suspicion that most probably this will be a malignant tumor, but there are not any specific radiologic characteristic that can differentiate specifically between malignant tumors. So then, of course, you need to proceed to have a biopsy in order to define better the histological aspects of the mass.
Okay. Are there any patients in whom you would request a PET scan on top of these other investigations?
If we consider that we have done our biopsy based on the result of the biopsy, then majority of the patients will need to have staging the disease. So in the vast majority of the cases, we will ask for CT scan to see the lungs, and neck ultrasound and abdomen ultrasound can be other complementary exams that we will ask. We ask PET-CT only in some specific tumors that are high-grade tumors, have a poor differentiation, and usually these are undifferentiated carcinomas, NUC, the neuroendocrine carcinoma, also known as SNEC, and the malignant mucosal melanoma. These are tumors that are very poorly differentiated. And regarding the squamous cell carcinoma, only the category G3 are tumors that will need to have a PET examination, a PET scan, to see better if there is any distant or regional metastases, if any systemic dissemination of the disease. For G1 and G2, squamous cell carcinoma is not necessary to have a PET scan, but only a chest scan, neck ultrasound.
Brilliant. So we've performed imaging on the patient. When you want to get a biopsy, do you perform this under general anaesthetic? And if so, are there certain things you are evaluating during examination of the nasal cavity under anaesthetic?
So in our practice, the biopsy is taken under local anesthesia in the vast majority of the cases. We have in our outpatient clinic all the equipment to perform biopsies safely, to control bleeding with bipolars, with hemostatic agents. So we regularly have biopsies in local anesthesia in the outpatient clinic. However, there might be some situations that you have a mass, a cancer, a tumor that is, for instance, in the maxillary sinus and is not having any component inside the nasal fossa. So this is not possible to take a biopsy in local anesthesia. So in that case, we need to have biopsy in general anesthesia by performing some kind of ethmoidectomy or opening of the maxillary sinus and taking the biopsy.
I see. So it really depends on the patient, the tumour, and what the imaging is showing us. So we've performed a biopsy and we've got all our investigations. We've got imaging, clinical evaluation, and histopathology. Now, Alkis, I'm going to introduce our listeners to the staging system for malignancies of the nasal cavity and paranasal sinuses. The staging system we use is the HJCC 8th edition. Tumours are staged according to the site, of which there are 3 sites: the maxillary sinus, the nasal cavity, and the ethmoid sinus. The maxillary sinus is the most common site of sinonasal malignancies, and tumours of the sphenoid and frontal sinuses are rare. The T staging of the maxillary sinus starts with T1, in which the tumour is limited to the maxillary sinus mucosa with no bone involvement. In T2 disease, the tumour causes bone erosion, including extension into the hard palate or the middle meatus. In T3 disease, tumour invades either the posterior wall of the maxillary sinus, subcutaneous tissues, the floor or medial wall of the orbit, or the pterygoid fossa. T4 disease represents advanced disease. In T4A, tumour invades the orbital contents, the skin of the cheek, pterygoid plates, infratemporal fossa, cribriform plate, or the sphenoid or frontal sinuses. T4B represents very advanced local disease and includes invasion of the orbital apex, brain, cranial nerves, or even the clivus. Alkis, what do you think are the main factors that affect patient prognosis?
So, of course, from different studies and from our experience also, the stage of presentation of the tumor is fundamental. So, of course, prognosis is affected by the T stage. So, if you have a T3, T4, patients will have a poorest prognosis than T1, T2. Then the grade of the tumor at the presentation will affect, like G1, G2 have better prognosis than G3 cases. And one other thing that is very important, of course, this is something that you can see after surgery, is the margins of resection. So positive margins are correlated with worse prognosis to the patient. So if we talk about CTNM, these are the risk factors. Of course, neck metastasis or distal metastasis have poorest prognosis to that. But also, if we talk about PTNM, then of course the surgical margins are critical for the outcome of the patient.
Nodal metastases certainly seem less common for sinonasal malignancies compared to other types of head and neck malignancies. Is this what you see in your clinical practice? Do you see patients presenting with nodal mets frequently, or is this a minority of cases?
So yeah, I agree. It's very rare to have nodal metastasis. It's not something that we see very frequently. It's really, really rare. Nodal metastases are more frequent when we have maxillary sinus cancers, and all different histopathologies can give nodal metastases. But maxillary sinus is the most frequent one and has, I think, around 20% of possible probability to have nodal metastases.
So we've got all the investigation which has been performed at this stage on this patient. Alkis, what are your main management principles in patients with sinonasal SCC? For example, what are your main principles of how you would manage these patients?
So when we have evaluated what is the T stage and what is the G, the grade of the tumor, then we can decide. So most likely, the vast majority of the cases that are G1 and G2 cases will go to surgery, even if they might be T3 and T4 cases. Of course, you have to see if there is a resectable or unresectable, because there are some T4Bs that are resectable and some T4Bs that are not resectable. So in the vast majority of the cases, we will go for surgery, and then usually radiotherapy, MRIT will be applied in the post-operative period for the patient. Otherwise, then we have different treatment options. We may use induction chemotherapy and see what is the response of the patient and decide to do or complete chemoradiation or have surgery and radiotherapy after. But this is depends of the response to the chemotherapy.
So for sinonasal SCC, it's clear from what you say how much importance tumour grade plays in the management of these patients in such a way that patients with grade 1 or grade 2 SCC are perhaps more likely to be given surgery as a primary treatment modality compared to higher grade tumours such as grade 3 SCC, which may be more likely to get non-surgical treatments such as neoadjuvant chemotherapy in the first instance.
Exactly. So yeah, G1, G2 are not don't have a good response to chemotherapy. G3 has a good response to chemotherapy. So this would be the case to perform a neoadjuvant chemotherapy and see what are the results. I agree with you.
So many patients with SCC are treated with multimodality therapies such as surgery plus adjuvant radiotherapy, for example. Are there any circumstances in your experience in which maybe monotherapies such as surgery alone or radiotherapy alone would be suitable?
So surgery alone can be considered in T1 cases. Small T1 cases are very selected T2, but usually I think only T1 squamous cell carcinoma can be the only category that can have only surgery without radiotherapy. About having only did you ask me also for radiotherapy alone?
Yeah, so there appears to be a role for primary surgery alone in patients with, for example, T1 SCC. But is there ever a role for primary radiotherapy alone for sinonasal malignancies?
So no, there's no evidence that radiotherapy has a role alone instead of surgery. The outcomes are worse. It has a lot of side effects. And then also we might consider that could be difficulty for radicalization in case of failure of the treatment, of the radiotherapy treatment. So usually radiotherapy alone has a role only for palliation with patients that cannot support surgery because they might die during surgery due to their comorbidities or they are very old. And so for an anesthesiological point of view, it's not possible to have surgery on them.
Okay, so really stage, grade and patient factors such as comorbidities are really three important factors in managing these patients. Alkis, are there any patients for whom surgery would not be an option?
So yeah, of course, surgery is not an option in all patients, as we said before, with a lot of comorbidities, so for his characteristics. Also, then it depends what is the extension of the disease. So we have a patient with orbital apex invasion, with cavernous sinus invasion, with brain invasion, having also a clear infiltration, meaning having edema, not only having a small involvement. So these are categories of tumors that cannot be, are not resectable. So and the prognosis will not change even if you perform surgery, because you will leave some residual disease that then will progress, and the patient will have a poor prognosis. And of course, when you have, as we told before, G3 cases, these are cases that are not amendable to surgery, but they need to have induction chemotherapy first.
So moving on to the next topic, the role of the elective neck dissection in patients with sinonasal malignancies. Which patients do you think warrant an elective neck dissection?
So elective neck dissection, we can perform in case of cancers of the maxillary sinus, advanced stages, T3, T4, because they have a good probability to have node metastasis. So this is one case if we talk about squamous cell carcinoma. One other case could be, but it's not squamous cell carcinoma, but in case of olfactory neuroblastoma with skull-base involvement, is most likely that we'll need to have elective neck irradiation, not dissection, but irradiation should be performed because there is a high possibility to have node metastasis at late time.
Okay, so it really depends on the stage and histopathology of the tumour you're dealing with. Let's move on to surgical approaches. Two of the main approaches to these tumours include endoscopic and open approaches. Alkis, how do you decide on which surgical approach to perform in these patients?
So yeah, of course, in the late years, the endoscopic approach has got more and more possibilities due to the experience that has gained from different surgeons, centers, understanding the anatomy, having better instrumentation. However, there are some cases related to the dimensions of the tumor, meaning by the extension of the tumor, that will not let the possibility to have an endoscopic resection. So we need to have transfacial resection or a cranioendoscopic resection, meaning that we need to collaborate also with a neurosurgeon for removing the cancer. So, for instance, when we have involvement of the frontal sinus, when we have extensive involvement of the orbit, of the dura that goes above the orbit, these are cases that it's not possible to reach from the nose, the sides. When the brain is involved massively with edema around, this is not resect. Also, when there is infiltration anteriorly to the nasal bones, the lacrimal pathways, and going inferiorly, when you have infiltration of the hard palate, this is not possible to remove by the soft palate. Is not possible to remove these tumors by an endoscopic approach, so we need to have associated an external open approach. Then one other possibility, but probably these are not resectable tumors, when you have extension to the nasopharynx and to the fascia, the prevertebral fascia. These are cases that cannot be operated through an endoscopic approach, but I think even through an open approach would be quite difficult.
So in a patient where you are performing an endoscopic sinonasal resection, what are your main surgical principles for approaching this sort of case?
Okay, so of course, when you perform surgery, whatever kind of surgery you want to perform, is important to respect the oncological radicality, and you need to perform surgery on clear margins. So regarding the endoscopic approach, we have standardized steps of the approach. So, of course, at the beginning, we need to have a removal of the portion of the tumor that is vegetating, so having a sort of the bulking and disassembling of the tumor in order to reach the pedicle of the tumor. Then the second step will be to create a big space big corridor in order to have a better possibility to work. So remove the septum, it's infiltrated from one side or both sides. Then having the opening of the frontal sinus by having a draft 3 sinusotomy, or which will permit you to have your landmarks anteriorly and will be very good exposure for having the skull base reconstruction at the end. Then the following step will be the centripetal resection, meaning to have the ethmoid completely removed by lateral to medial. So having all the ethmoidal box removed together with the tumor, and then resecting the skull base with both ethmoids together and opening the dura if there is invasion of the dura, which will then give us, of course, the radicality by having margins in all the surrounding areas, all the dura, the olfactory bulbs, and then we have the reconstruction of the skull base with using usually fascia lata.
I see. And what do you find are the main difficulties in performing an endoscopic resection, and are there any measures you take to make this operation easier and to address some of these difficulties?
So first of all, the inversion of the anatomy. So these tumors will make bone erosion, will change the normal anatomy. So of course, you need to have performed a lot of surgeries for inflammatory disease before, having done a lot of dissection courses in order to know completely the anatomy and be orientated when you perform such a case. Bleeding is a main factor, so you need to have a quick debulking in order to just have the pedicle of the tumor that will bleed less. And also you need to use the 4 hands to have the aspiration, the suction of the blood to help you see better. You need to have hemostatic agents like Flow-Seal to stop bleeding if there is heavy bleeding. And also instrumentation is very important. It's not possible to have such a kind of surgery in a department that does not high-speed drills, does not have navigation, intranasal Doppler, lasers, all instruments that are important to have safe surgery. And at the end, the reconstruction of the skull base is a procedure that could be tricky and difficult, so you need to have performed before many cases of CSF leak plasty, skull base reconstruction before for CSF or meningoseals in order to be experienced on that and can manage the reconstruction of the skull base after cancer removal.
Wow, so there's a lot of things there really in terms of, I suppose, having the right expertise and training and being in a centre that's used to dealing with a high volume of these patients and has all the right equipment for doing these cases. Alkis, so very interesting. Are there any patients in whom you think adjuvant chemotherapy plays an important role?
So regarding adjuvant chemotherapy, there are 2 scenarios, 2 cases that patients might need to have chemotherapy associated to the radiotherapy. So one case would be when at the definite histopathology report, there are positive margins. And the other scenario is that in the histopathology slices, there is evidence of angioinvasion or neural invasion from the tumor. So chemotherapy will be sensibilizing radiotherapy in order to destroy any residual cells and residual tumors over there. However, we know that patients above 70 years old, if they have comorbidities, will likely not benefit from chemotherapy because of the late toxicity. So usually is not something that is performed even if we have such cases.
And what is the role for neoadjuvant or induction chemotherapy? I think you touched on that earlier in the podcast.
Yeah, so neoadjuvant chemotherapy, induction chemotherapy could be beneficial in case of advanced stage tumors. Usually they present as T4 cases. They are unresectable because most likely they involve both the orbits, they involve the brain, so it's very high volume tumors. And these tumors will usually have a good response to chemotherapy. So the aim will be to have a downstaging of the tumor So what happens is that this patient will have induction chemotherapy. Usually oncologists use cisplatin, a mix of cisplatin, 5-fluorouracil and docetaxel. And they measure the volume of reduction of the tumor after each cycle. So if after the fifth cycle there is a good response, meaning there is more than 80% of reduction of the tumor, so this is a good response and the patient will complete his treatment by combined chemoradiation. On the other hand, if the patient has not a good response and we see that there is less than 80% of response, then the patient, if it's possible, will complete surgery with adjuvant radiotherapy.
So, Alkas, what is your main strategy on clinical follow-up and radiological surveillance in post-treatment patients who are treated for a sinonasal malignancy?
So it's very important to follow up the patient for lifelong time. We don't stop follow-up after 5 or 10 years because there is possibility to have recurrence of disease even after 10 years. So in our institution, we perform lifelong follow-up. And initially, in the first year, we have endoscopic examination every 2 months and an MRI of paranasal sinuses every 4 months. Then, from the second to the fifth year, the endoscopic examination is between 4 to 6 months, every 4 to 6 months, and the MRI is every 6 months. Then, after the fifth year, we perform once a year endoscopic examination and once a year an MRI. Regarding systemic examination, we perform to our patients once a year a neck ultrasound and once a year a total body CT scan. And for the high-grade tumors like G3 squamous cell carcinoma or SNOG mucosal melanoma, we perform a PET CT scan.
I see, so very intensive post-treatment surveillance of these patients.
Exactly.
We've covered quite a lot today, and Alkas, you've given us some truly great insights into these fascinating conditions. I would like to take this opportunity to thank you for coming onto the podcast. And to our listeners on today's podcast, I hope you found this useful and I look forward to welcoming you back to episode 3.